Welcome all. Today's class is on bacterial sepsis in pregnancy. This is Green Top Guideline number 64A, published in April 2012. We begin with our quote, Master MRCOG with concept-oriented clarity. So, bacterial sepsis in pregnancy, this topic is going to be very important from examination point of view. Actually, there are two guidelines. One is a 64A, another is a 64B. Today, we will discuss only 64A, but both guidelines are important from the examination point of view. So, sepsis in pregnancy, there is a significant increase in the maternal death in the UK because of sepsis. In 2006 and 2008, sepsis became the leading cause of direct maternal deaths in the UK. Group A streptococcal infection caused 13 deaths. Severe sepsis mortality, here please remember the figures of severe sepsis mortality, 20 to 40% mortality rate for severe sepsis with organ dysfunction. Okay, so severe sepsis mortality is 20 to 40%. Okay, and mortality increases to 60% if it is a septic shock develops. So if you are asked about the mortality due to septic shock, it will be 60%. If it is due to the severe sepsis, the mortality is in the range of 20 to 40%. Hope this is very clear to you. This is one of the SPA. Okay. Early recognition and treatment. Studies in non-pregnant population show that early recognition and treatment improves the survival rate. Now there are certain definitions. Sepsis is nothing but the infection plus systemic manifestation of infection. Severe sepsis is sepsis with organ dysfunction or tissue hypoperfusion. Okay, and septic shock is a persistent hypoperfusion despite adequate fluid replacement therapy. So that is a septic shock. In septic shock, there is a persistent hypoperfusion in spite of adequate fluid replacement therapy. Okay, so these are the definition. Now, what are the risk factors for maternal sepsis? These are obesity, then impaired glucose tolerance, impaired immunity or immunosuppressed medications, anemia, vaginal discharge, history of pelvic infection, history of group B streptococcal infection, amniocentesis and other invasive procedures, cervical encerclage, prolonged spontaneous rupture of membrane, group A streptococcal infection in close contacts or family infection, and black or other minority ethnic group origin are at risk of maternal sepsis. Okay, so in the scenario, you look for if these are present and look for then whether it is are you dealing with the scenario which is related to maternal sepsis. Okay, now the most important, it covers this particular guideline. What does it cover? It covers the recognition and management of serious bacterial illness during antenatal and intrapartum periods. Okay, so the current guideline which we are going to discuss will cover antenatal and intrapartum periods. It will exclude the viral, fungal and other infections. Separate guidelines are there for puerperal or the bacterial sepsis. Okay. Clinical signs suggestive of sepsis. Common symptoms are pyrexia or hypothermia, tachycardia, tachypnea, hypoxia, hypotension, oliguria, impaired consciousness, and failure to respond to the treatment. Not all symptoms may be present, and severity is not always indicated by the presence of symptoms. Monitoring and observation. Record vital signs, that is temperature, pulse, blood pressure, respiratory rate on MEOS chart. Annual training on MEOS chart used for staff taking observations. So this MEOS chart is very, very important. Okay, there is modified early obstetric warning score. Okay, challenges in diagnosis. Sepsis symptoms in pregnancy may be less distinct than in non-pregnant women, and high suspicion is necessary due to variable presentation. Now, what are the specific signs which we need to look for? Genital tract sepsis, there may be severe abdominal pain and tenderness which is not relieved by the analgesia. Then preterm labor, don't treat the preterm labor, always look for some focus of infection. So severe infection may trigger the preterm labor. So if you are dealing with the preterm labor, look for the source of infection. And third, it can be a case of toxic shock syndrome. The symptoms of toxic shock syndrome may include nausea, vomiting, diarrhea, severe pain. This pain may be because of necrotizing fasciitis. This can also be a EMQ. Okay, watery vaginal discharge and generalized rash. Okay, and conjunctival suffusion. If you get these 2-3 things, then your diagnosis will be toxic shock syndrome. So please look for this conjunctival suffusion and watery vaginal discharge, generalized rash and necrotizing fasciitis or severe pain. Then most probably you are dealing with a diagnosis of toxic shock syndrome, and your option for selection may be toxic shock syndrome. Then what are the clinical features suggestive of sepsis? Okay, fever or rigors, diarrhea or vomiting may indicate exotoxin production or the early toxic shock. Okay, so this diarrhea, vomiting, generally exotoxin production, because of that it is there. The rash, streptococcal maculopapular rash or purpura fulminans is there. Abdominal and pelvic pain and tenderness. Offensive vaginal discharge, smelly suggests anaerobes. Serosanguinous suggests streptococcal infection. Okay, then productive cough and urinary symptoms. So these particular nature of these particular secretions, vaginal discharge also, remember, sometimes they may give this particular thing, the oral sepsis, and look for, they may expect the some diagnosis. Serosanguinous suggests streptococcal infection, smelly suggests anaerobes, etc. etc. Then coming to the appropriate investigation for suspected sepsis, what investigations you are going to carry out? You will do the blood culture, serum lactate, imaging studies, and additional samples. MRSA screening is also required, and prompt imaging is required. Now coming to the blood culture. Blood culture is the key investigation, and this is to be done before starting the antibiotics. Antibiotics should not be delayed for microbiology results. You just collect the sample and give the antibiotics. Don't wait for the results to come. Okay, later on the antibiotics can be changed. Then serum lactate. This is also one of the most important thing, and major serum lactate within 6 hours if the maternal sepsis is suspected. This, remember, 6 hours. This is there is a sepsis 6 bundle. Okay, so serum lactate is to be measured within 6 hours if the severe sepsis is suspected, and lactate more than or equal to 4 millimoles per indicates tissue hypoperfusion. This lactate more than 4 or equal, this figure is also very, very important, more than 4. So serum lactate is to be done within 6 hours, and 4 or more level of lactate indicates severe tissue hypoperfusion. Then imaging studies performed promptly to confirm the infection source. Additional samples, obtain blood samples on clinical suspicion, maybe throat swab, urine, depending upon the system involved, you will take the sample. Sample must be obtained before starting the antibiotics, but antibiotics should not be delayed. Okay. Then MRSA screening. If MRSA status is unknown, send a pre-motion nasal swab for rapid screening. Okay. And prompt imaging should not be delayed due to pregnancy and may help to identify the infection source for targeted treatment. So just because she is pregnant, don't delay the imaging. Okay. Now there is a surviving sepsis campaign, SSC. Okay, surviving sepsis campaign. So they have given resuscitation bundle. These are the tasks which is to be performed within 6 hours of identifying the severe sepsis. So what are the things which we have to do? One is obtain the blood culture prior to the antibiotic. Second, give IV antibiotics within 1 hour of recognizing the severe sepsis. IV antibiotics should be given within 1 hour of the recognizing or suspicion of the sepsis. You will give within 1 hour. Okay, and serum lactate is to be measured within 6 hours of the suspicion of the severe sepsis. Now, if there is a hypotension and or serum lactate is more than 4, give crystalloids or equivalent with a dose of 20 ml per kg. Okay, so first you give IV antibiotics. First you will send the culture. You will give IV antibiotics. Measure the serum lactate. If the serum lactate level is high or if the patient is having hypotension, give 20 ml per kg crystalloid. If there is a persistent hypotension and or there is a lactate more than 4, the patient is in shock, then you will add vasopressors. So first give crystalloids. Okay, in spite of that, if there is a hypotension, then add vasopressors, because you are likely to deal with the septic shock now. And maintain mean arterial pressure more than 65. If there is a persistent hypotension, lactate is more than, then you monitor CVP also. So you will add vasopressors. You will try to maintain mean arterial pressure more than 65. You will also maintain the CVP more than 8 millimeters of mercury and achieve central venous oxygen saturation SCVO2 more than 70% or mixed venous oxygen saturation more than 65%. Okay, central venous oxygen saturation should be more than 70% and mixed should be more than 65%. Okay. Now, indications for transfer to the ICU. Okay, what are the indications? Cardiovascular system such as hypertension, raised serum lactate, persisting despite fluid resuscitation. We have seen first is a fluid resuscitation, means once you send the investigations and all, blood culture, serum lactate and all, IV antibiotics given, start with the fluid resuscitation. But in spite of that, there is the patient should be shifted to ICU. Okay, and mainly for the inotrope support. Respiratory, such as pulmonary edema, mechanical ventilation, airway protection. For this, the patient requires ICU admission. Renal dialysis, neurological, significantly decreased conscious level, miscellaneous multi-organ failure, uncorrected acidosis, hypothermia. Collaborative care for women in sepsis. It is always a multidisciplinary care which is required. So frequent observation, such as regular monitoring with MEOS chart, is recommended for early identification. Urgent referral, critical care team involvement for severe or rapidly deteriorating cases. Consultant obstetrician should be involved, and expert advice. Consultant microbiologist and infectious disease physician. So never forget, when you are dealing with these sepsis, there is a lot important role of consultant microbiologist and infectious disease physician. They should be urgently consulted if serious sepsis is suspected. Okay, so it is always a multidisciplinary team management. Then MEOT chart, okay, used for all maternity inpatients to identify seriously ill pregnant women, helps in referring to critical care and obstetric anesthetic teams based on local guidelines. There has to be goal-directed resuscitation, proven to improve the survival for septic shock patients. Surviving sepsis campaign resuscitation bundle should be started pending ICU transfer. So whatever is this bundle, we have just seen what exactly steps are there. Then patient should be shifted to ICU. Decision made by the critical care team, obstetric consultant, obstetric anesthetist. Cardiac output monitoring, ventilatory support, renal support typically require ICU transfer. Common organisms, including hospital, these are the SBAs which are asked. Most common is a group A, beta hemolytic streptococcus, and second is a E. coli. These are the common ones. Okay, mixed infections often occur in chorioamnionitis with both gram-positive and gram-negative organisms. Coliform infection associated with urinary sepsis, PPROM, and cercalage. So these things are associated with coliform infection. Okay, so sometimes they will ask you the common infection, but if they are asking with respect to this, then select E. coli. Okay. Then anaerobes, they are less common, but include Clostridium perfringens or gas gangrene. This is also SBA they have asked in the past. Okay, so here you have SBA. That is what this slide is important. Okay. Then empirical and specific antimicrobial therapy. Here also there are SBAs on this slide. Broad spectrum antibiotics. IV antibiotics should be administered within 1 hour of the suspected severe sepsis, with or without septic shock. Genital tract sepsis, early treatment with high dose broad spectrum IV antibiotics is critical. And empirical therapy, use antibiotic active against gram negative bacteria, the one which prevents exotoxin production from gram positive bacteria, and follow local microbiology policies and narrow treatment once the positive organism is identified. Now what they are talking about, cefuroxime and metronidazole. Okay, previously this cefuroxime has been widely used. Okay, so previously recommended for genital tract sepsis, but cefuroxime is now less used due to the Clostridium difficile risk. Okay, neither it covers MRSA, Pseudomonas, or extended spectrum beta lactamase organism. So that is why cefuroxime has got these many limitations. So it will not cover MRSA. Pseudomonas and ESBL will also not be covered. Then local guideline, follow hospital guidelines for appropriate antibiotics as resistance patterns vary across the UK. Source control, along with antibiotics, identify and manage the infection source, such as delivering the baby in some cases. Okay, so sometimes you may have to consider the delivery of the baby also. Okay. So antimicrobial choices and limitations of antimicrobials. Again, here there will be SBA. Coamaxclove. What is the issue with the coamaxclove? Necroticizing enterocolitis risk in the neonates. Okay, so coamaxclave is not preferred. Again, it will not cover MRSA, Pseudomonas. Same thing what we have seen with cefuroxime, that also not cover MRSA and Pseudomonas. Here also coamaxclave not covering MRSA, Pseudomonas, plus risk to the baby. Metronidazole will cover only anaerobes. It will not cover gram positive, gram negative. Then Clinda will cover anaerobe, but it covers most streptococci, staphylococci, and it will also cover MRSA, switches of exotoxin production, reducing mortality. It is not nephrotoxic and renally excreted. So clindamycin is covering staphylococci, that is gram positive. Many MRSAs are covered. It will switch. So this is mainly gram positives are getting covered and non-nephrotoxic and renally excreted. Okay. Then piperacillin and tazobactam, it will cover all, but it will not cover MRSA, and it is renal sparing like aminoglycosides. Okay. Then gentamicin poses no issue in normal renal function. If given regularly, serum levels must be monitored. Single dose 3 to 5 milligram per kg, provided the normal renal function is there. Sometimes they ask you, they will give you the creatinine clearance and they might ask you the dose. Okay. So gentamicin, normal creatinine clearance 3 to 5 milligram per kg can be given. What is the role of IV immunoglobulin in sepsis? So what is the indication? Used for severe invasive streptococcal or staphylococcal infection if other therapies fail. What is the mechanism of action for immunoglobulin? It is immunomodulatory in nature. It neutralizes super antigen effect of exotoxin, inhibits TNF and interleukin production, effective in exotoxic shock, like streptococcal or staphylococcal toxic shock syndrome. Limited benefit in gram-negative sepsis. This IV immunoglobulin is mainly effective in the exotoxic shock. Okay, gram-positive. Contraindications: if the patient has got a congenital immunoglobulin A deficiency. Consultation: discuss use in severe sepsis with infectious disease or microbiology expert. Available from the blood transfusion department and administered via blood warming device. Then fetal monitoring and delivery consideration. As I told you, sometimes in sepsis we might have to deliver the patient also. Okay, what should be the timing of the birth? Timing of the birth should be decided by the obstetrician and the mode of the delivery, timing of the birth is to be decided by the obstetrician. Consider birth if it is beneficial for the mother, baby, or both. Then preterm delivery, consider antenatal corticosteroids for fetal lung maturity if sepsis is present. Intrapartum care, always continuous electronic fetal monitoring is recommended. We have seen all the indications for continuous electronic fetal heart rate monitoring. Okay, CTG changes, baseline variability or deceleration should prompt reassessment of maternal condition. Anesthesia, avoid epidural or spinal and prefer general anesthesia, typically required for cesarean section. So in sepsis, always if you have multiple options for the delivery, the option with general anesthesia will be preferred. Okay. Then fetal risk, intrauterine infection increases the risk of neonatal encephalopathy and cerebral palsy. Preterm delivery, again antenatal corticosteroids can be considered. Then fetal heart monitoring, electronic fetal heart monitoring is crucial even in absence of pyrexia. Delivery decision, maternal instability increases the maternal and fetal mortality, especially if infection source is not intrauterine. Decision should consider severity of the maternal illness, gestational age, and fetal viability. So this is decided by the obstetrician team only. Okay. Now coming to the prophylaxis for neonate family members and healthcare workers. Neonate prophylactic antibiotics if the mother has got a group A streptococcal infection. So then baby will receive prophylactic antibiotic. Any close household contacts, warn the contacts to seek medical attention if they develop the symptoms and consider antibiotic prophylaxis for contact. Okay. Then healthcare workers, antibiotic prophylaxis for workers exposed to the respiratory secretions from women with group A streptococcal infection. Suppose mother is diagnosed with group A streptococcal infection and the worker is exposed to respiratory secretions, then antibiotic prophylaxis is indicated. Guideline: follow local or national guidelines for group A streptococcal infection control. Discuss with neonatology colleagues regarding antibiotic prophylaxis for babies born to mothers with sepsis. Okay. Now, infection control consideration. What is the mode of transmission? Group A beta hemolytic streptococcus and MRSA are easily spread by the hands of healthcare workers and close contact in the households. So these are the modes of transmission. Isolation. Women with suspected or diagnosed group A streptococcal sepsis should be isolated in a single room with ensuite facilities and minimize spread to other women. Notifiable infection. Invasive group A streptococcal infections are notifiable. Notify the infection control team and consultant for communicable diseases. Local guidelines. Follow the hospital-specific isolation and contact precautions, and seek local advice for infectious control colleagues. So that finishes this particular guideline. Thank you.